Greetings to our lecturer and fellow classmates. We are from Group 8. We will be presenting about fatty acid metabolism disorder, specifically focusing on carnitine transporter deficiency. This is our group member, and we will begin our presentation now.
Carnitine transporter deficiency, CTD, also known as primary carnitine deficiency, PCD, is a rare genetic metabolic disorder caused by mutations in the SLC22A5 gene. This gene encodes a protein responsible for transporting carnitine into cells, particularly muscle, heart, and liver cells, where it is essential for the transport of long-chain fatty acids into mitochondria for energy production. In individuals with CTD, defective transport leads to low level of carnitine in cells, impairing the ability to use fat as an energy source, especially during fasting, stress, or illness. CTD is inherited in an autosomal recessive manner, meaning a person must inherit two faulty copies of the SLC22A5 gene, one from each parent, to develop the disease. The severity and onset of symptoms can vary, ranging from severe neonatal presentations such as cardiomyopathy, hypoketotic hypoglycemia, and sudden death, to milder forms that may only be discovered during routine screening or after an illness. Fortunately, once diagnosed, CTD can be effectively managed with lifelong oral supplementation of L-carnitine, which restores intracellular carnitine levels and help prevent metabolic crisis and long-term complications.
So good day to everyone and doctor. I'm Pang. So I'm going to present about this specific inherited metabolic disorder called primary carnitine deficiency and also known as carnitine transporter deficiency. To understand these conditions, we need to first look at how our body process fat for energy. So fatty acids, especially the long chain ones, are the main sources for energy. So especially during fasting and prolonged exercise. But to be used for energy, these fatty acids need to be transported into mitochondria. This is where carnitine comes in. Carnitine is a special molecule that helps move long-chain fatty acids from the cytoplasms into mitochondria. So where they're broken down through a process called beta oxidations. This step is vital for generating ATP, which powers our body. So in primary carnitine deficiency, this process breaks down because of the faulty carnitine transporter called OCTN2. So this transporter normally helps absorb carnitine from food and reabsorb in the kidneys. So when it doesn't function properly, carnitine levels inside cells drop dramatically. So without enough carnitine, long-chain fatty acids can't enter the mitochondria and therefore can't be broken down into energy. This leads to numbers of serious problems, especially during fasting, illness, or stress, when the body depends on more fat for energy. So patients may experience like low blood sugar without production of ketones, fatigue, muscle weakness, and large liver, and in more severe cases, so like heart problems like heart attack something. So this is because fats begin to build up in tissues such as the liver, heart, and muscles instead of being used as energy. So now let's look at the gene mutation for this case. So the gene responsible for this condition is SLC22A5, which encodes the OCTN2 transporter. This gene is inherited in a autosomal recessive manner, meaning both parents must carry the mutation for a child to be affected. So over the 180 different mutations have been identified in this gene. One common example is missense mutations called C.136C2T, which changes a single amino acid into the protein. So these mutations lead to reduced or absent transporter activity, which causes systemic carnitine deficiency. Understanding the genetic basis of PCD of all this deficiency allows for the early diagnosis through newborn screening and effective treatment with carnitine supplements.
Hello everyone, my name is Nur Aina Nadia binti Muhammad and I will continue to talk about signs and symptoms at different life stages. So for my finding, I found signs affected by CTD, or we call it as carnitine transporter deficiency. Firstly, it can enlarge liver, or we call it as hepatomegaly. This can be felt by a doctor during the physical examination. Second is low blood sugar, or we call it as hypoglycemia. This can be ensured by a glucose test. So next is for my finding, I found that it can weak the muscle tone. It can be seen by physical movement check. So the symptom of CKD by age group. So here we have three categories of the age group, which is infant 0 to 12 months, children 1 to 10 years, and adolescent and adult 11 years. So for the infant, it may cause symptoms of vomiting or poor feeding, sleepiness or called as lethargy, and risk of sudden death if untreated. So for the children, it may cause recurrent hypoglycemia, muscle weakness, and enlarged heart, or we call it a cardiomyopathy. For adolescent and adult 11 years plus, it may cause on chronic fatigue or muscle pain, risk on heart rhythm problem, and sudden cardiac arrest. And mostly it causes fasting. So next is the symptom may happen during the routine screening or after an unexplained heart issue.
Alright, my name is Khairuddin, and I will talk about detailed description on the diagnostic method or technique used to detect the disease. Okay, first we have newborn screening. It is performed using red blood spots from heel prick test. It detects elevated medium chain acylcarnitines, especially C8, or we can call it octanoyl carnitine. Early detection prevents metabolic crisis and sudden death. It's a standard in many countries, newborn screening programs. Okay, the second one, we have urine organic acid analysis. Okay, it detects increased level of medium chains decarboxylic acid. Example, subatic acid. It is used during symptomatic episodes like hypoglycemia or metabolic crisis. Okay, and the third one, we have molecular genetic testing. It confirms diagnosis by identifying mutations in the SCADM gene. The common mutation is C985A, and then it is performed on DNA from blood sample. It is useful for family screening and genetic counseling. Okay, and then the last one, we have enzyme activity assay. It's measure MCAD enzyme activity in cultured fibroblasts or lymphocytes. It is less commonly used now, but it is helpful if genetic results are inconclusive.
Hi and Assalamualaikum. I am Putri, and now we will continue with the last part of the presentation, which is practical tips to treat or alleviate carnitine transporter deficiency effect. First of all, the main treatment for this disease is to use L-carnitine supplement with the dosage between 100 to 400 mg per day, as this will help to replace the missing carnitine in our body to allow fatty acid transport into mitochondria for energy production. The next treatment for this disease is to modify our diet into eating meals with high carbohydrate and low fat levels to reduce the dependence in fat metabolism and to help prevent energy crisis. The third tips is to do regular monitoring to check carnitine levels, liver enzyme, and to perform heart evaluation in order to detect any complication early. Last but not least is to manage our lifestyle by avoiding intense physical activities and by carrying medical ID in the form of card or bracelet to identify CTD cases for any emergency care. Thank you.